Let me just get us going here. All right. All right. So, hello, good morning, good afternoon. And my name is Dana Dolan, and I am a contractor working with the health informatics team in CDC's Division of Global HIV and TB. And today we are meeting in the context of Shiriki, which is an informal community of people who work in global public health informatics with a focus on HIV and TB. And the conversations in this community are led by the community and not necessarily by CDC. So if you're not a member of the community and you would like to be one, we have a very brief form to request membership, and I'll put the link to the membership form in the chat in a moment. And also, if you're attending the session because someone else has invited you, if you could use that form to let us know, you could use that same form. That just helps us know who's here and where you came from. So today we're looking at a case study from Malawi. The MOH Department of HIV and AIDS partnered with Fjelltopp and UNAIDS to implement a fair data catalog using the open source platform CKAN. And fair, of course, means that data are findable, accessible, interoperable, and ultimately reusable. You're welcome to ask questions using the Zoom chat window, and we will have time for conversation after the formal presentation. And we do ask that you mute your microphone unless you're speaking to everyone. We've allotted 60 minutes for the session, and we will make, again, the transcript, chat, and recording available after the session. And now I will turn it over to Jonathan Berry of Fjelltopp.
Thanks, Daniel. Firstly, a massive thank you to you and everyone at CDC for organising this community. I've been delighted to join. I'm quite a new member, actually, but I've found the recent presentations really helpful, insightful. So a massive thanks to everyone who contributes to this community. I hope what I have here is helpful and insightful too. The title of this presentation I've given is Data Catalogues for Fair Health, Data and Documentation Dissemination. And it's going to look at a case study, which is a project that we have with the Malawi Department for HIV, AIDS and Viral Hepatitis. It's an absolute joy to be joined by Dr. Andreas Jan from the department. Thank you, Andreas, for being here. He will share a little bit about the project and why it's important to the department. But I will just cover some introductory slides before we get into that, I think. Yes, let's dive straight in. I want to begin actually not by talking about Malawi, but WHO, Romania. Romania is a very different country to many of the countries we work with because it is in fact relatively wealthy. It's a middle income country and it's a member of the EU. And it shares a border with Ukraine, which, as I'm sure we're all aware, is an ongoing war zone at present. As such, a big part of the WHO's work in the country is working on their refugee response action plan. And Fjelltopp had been contracted to help with the monitoring and evaluation of that plan. Refugees from Ukraine in Romania are offered a completely free package of healthcare services, which is fantastic. And the basic idea of our work would be that we put together some Power BI dashboards and reporting showing some summary statistics regarding how that refugee population is accessing and using healthcare within the country. It was a project, of course, that in essence was relatively simple, except that it depended upon data, and it depended upon data that we did not immediately have access to. It was data that we were confident was being readily collected by various institutions across the country. And in reality, the trouble was that finding, accessing, and reusing that data proved immensely difficult, even though it existed. Firstly, we had to just find out what relevant data existed. That involved a lot of emails, that involved a lot of meetings with different institutions. Then we had to understand that data. We had to get into how the indicators were defined, the field definitions, the data structures, the source information. And then we had to secure access to that data. We had to get the required approvals, and we had to agree a data sharing mechanism, which in the end always turned out to be an Excel spreadsheet attached to an email. And this whole process involved a huge amount of time and resources, both from our side as the WHO office in Romania, but also from the Ministry of Health and from the various institutions, the National Health Insurance House, the National Institute for Public Health, etc. This is the problem that we're trying to dig into today. The problem is that partners struggle to support ministries of health because they can't easily find and access the necessary data or documentation. Let me tell you a little bit about who I am and about the organization I work for. Fjelltopp. And Fjelltopp is a data engineering and software engineering consultancy working within public health and international development. And we say that we're on a mission to help harmonize health data around the world. We work with more than 13 different UN offices, and there are more than 50 different countries using our solutions. And one of our solutions, maybe some of you are familiar with, it is called the AIDS Data Repository, and it helps to support the UNAIDS supported country estimates process for HIV and AIDS. It was through that project that we actually met up with the team at Malawi. And it's been an absolute joy to partner with them on this work. So the problem is that for many, process, and we've seen this time and time again through our work with the UN, a lack of data dissemination infrastructure is obstructing collaboration and progress towards Sustainable Development Goals 3, health and well-being, and 17. Ministries of health in low middle income countries are now generating masses of electronic data and documentation. There's been an absolute explosion in the sector over the last decade. But data dissemination is still generally a very laborious, very manual effort arranged by extended email conversations and manual spreadsheet management in our experience. And this, of course, is placing huge pressure on already overworked data management teams. These are some of the challenges that we've seen ministries of health face. How do program reports? How do academic partners keep up to date with your approved program data and estimates? How do staff ensure that they can access the latest version of your clinical guidelines? How is your finalized data and documentation archived for long-term access, both by external partners and internal partners? The solution is not a dashboard. This is in our opinion. The solution is not another SQL database or even a SharePoint. Countries have already put in place so many different tools to collect, to clean, and to review health data. There are big challenges around this that we are battling on a day-to-day basis, but despite these challenges, data is already being reviewed, it is already being shared with partners, and reports are already being produced and published. Epidemiological estimates are being created, often with the support from other institutions. And I guess the point I'm making here is, where are all these static artifacts stored? And in our experience, it's often in emails, it's often in individual machines or internal systems. And in some rare cases, we have found externally facing repositories, but these repositories have had very limited functionality and quite poor implementation of sound data management and dissemination practices. And so that is the big idea that I'm pushing here. That we want to maximize the impact of practices. Improving the quality of your data dissemination will increase the impact of the data. And given the pain and trauma we all go through to collect, review, clean, and manage this health data, I'm sure we all agree that we want to maximize its actual impact. Now, there is so much literature out there to help you think about. I found this particular framework really helpful, really digestible, in part because it's so simple. but also so powerful. It's a framework called FAIR, and it essentially is very simple. It just says that your data should be findable, it should be accessible, it should be interoperable, and it should be reusable. And it's mentioned and supported by the WHO in their WHO data management principles. It's something that's come out of the academic science community. And I believe it should apply to health data as well. If you want to find more, you can go to gofair.org. It's very simple, but it's a great starting point for thinking about data dissemination. You might want to think about these questions. How would someone find relevant data and documentation produced by your institution? How would someone arrange access to that data securely? Can interoperable systems pull that data automatically, or does it require manual staff labor to extract? Is metadata easily available and published to explain the data and give people confidence to reuse the data? Now, again, I don't know about your particular context, but in many of the contexts that we work within, the answer to these questions is actually no, not really. But we do believe that this will open, improving data dissemination strategy will motivate further data quality work. It will direct that further data quality work. It will free up time and resources for your data management team to work on data quality. It will open up possibilities for collaboration with other organizations. It will encourage innovation. So I guess that is to say that this is a problem we believe should be tackled and solved now. Don't leave it for some utopian future where your health data is 100% accurate, complete, and timely. Any institution responsible for sharing reports and data with third parties should have a platform and a strategy to manage, archive, and disseminate those artifacts. And the final comment on this section, I just want to point out that FAIR is an acronym that Benares FAIR does not mean public. We at Fjelltopp believe open data is genuinely a great thing to strive for, and WHO themselves say that in their very first data management principle that wherever possible, health data should be treated as a public good. And so, of course, we'd encourage every Ministry of Health to put in place a platform for open data, remembering, of course, that that does not mean that all their data must be made open. However, we have seen firsthand that in many places open data is just not a practical proposition. We wonder in those cases whether metadata could be considered open and data kept private, but that's a separate presentation. Anyhow, whether your data and reports should be publicly accessible is beside the point. The data should be fair to those who are entitled to access that data, whether that data is kept privately or publicly. And that story I gave from WHO Romania at the start was a situation where we weren't trying to gain access to public data. We had approved access to data, but we still struggled to find the data, to interoperate with the data, to reuse the data. Now, I'm not just trying to present problems and big abstract ideas. We do have a solid solution to present, data catalog. So first of all, what is a data catalog? Well, a data catalog is an organized and searchable list of all the data sets and documentation from your institution that are accessible to a particular individual. They bring together data, they bring together metadata into one place, into one repository, and they make sure that that is findable, it's accessible, it's interoperable, and it's reusable. And so it acts as a one-stop shop and a long-term archive for all those finalized static assets that you are probably already producing, already creating, already approving. CKAN is perhaps a platform It's a hugely popular open source project written in Python and JavaScript. And it's used by the US government. It's the basis of data.gov, but it's also used by the Canadian government, the Australian government, the UK government, the Swiss government. It's used throughout the public sector around the world. And it's also powering the Humanitarian Data Exchange, run by UN OCHA, I believe, the Raw Internal Data Library for UNHCR. The NHS have an open data project that is powered by CKAN. And Fjelltopp, of course, have developed this AIDS data repository, which is a CKAN tool, as well as our case study today, which is the document management system for the Ministry of Health in Malawi. So the point I'm making here is that this is not our small new tool. This is a widely adopted and widely tested solution. Now, CKAN provides straight out of the box metadata entry. Helps to make your data findable and reusable because a powerful search engine is also made available to search that metadata. You can search the data, but also filter the data by different facets, by tags, by categories, by dates, by file types. CKAN provides fine-grained access control to your data so that not all your data needs to be public. Some of it can be kept private and shared with just key individuals or key organizations. CKAN is also able to provide versioning and change tracking for your data, helping give confidence for data reuse because it allows people to see who's been changing the data and how over time. It has a fully functional API that lets a machine, a program, a script do everything that a human can do. And it provides a secure, central, backed up archive. You know, any CKAN project that we've worked on, we've been backing up data to at least 2 different regional availability zones and 2 different cloud infrastructure platforms. There are also data previewing and visualization tools available. But I think it's important to say that what a data catalog is and what a data catalog isn't a data dashboarding project. This is a data cataloging project. It's not a data collection system. It's a long-term storage solution. It's not a data cleaning tool. It is a data publishing tool. It's not a siloed standalone system. It should be an interoperable hub drawing on all these other systems as sources. And it's not just for public data, it's for both public and private data. And it's certainly not an untested idea of ours. It's a widely adopted solution around the world. And it's not a purely technical project because principally behind this, it's a system to promote data management and dissemination best practice across your institution. So we have actually had the privilege of working is exactly this. It is a CKAN data catalog. At this point, it makes sense maybe for me to step aside and to invite Andreas Jan from the department just to introduce himself and to introduce a little bit about why this project is important to them. Thanks, Andreas.
So thank you very much, and good morning and good afternoon and good evening, wherever you are. I can see there are quite a few colleagues and ex-colleagues on the list of participants. That's great to see you and meet you again. This is my first time on the Shiriki community, so I'm new to this, but it seems like a great match to what we've been trying to do for a long time. I just wanted to briefly introduce myself. So I'm a technical assistant under the PEPFAR program, long-term, working for the HIV program here in the Ministry of Health in Malawi since 2008, in fact. And this vision of creating a kind of outward-facing repository for all of the information, published reports, guidelines, circulars, data exports is actually not new. We started this in 2013, I believe. We had a first iteration of a website for the HIV department, which already had the idea of this document management system incorporated. It was just that the technical execution was quite weak, and we had challenges to maintain it and to sustain it. I think many of the points that Jonathan raised about the ease of interacting with the system were quite fundamentally wrong with the first attempt. And so we were really excited to try and work with this team, as Jonathan mentioned as well. It was the AIDS data repository that we had interacted with for a couple of years before through the UNAIDS estimation workshops that led us to the Fjelltopp team and to CKAN. And it turned out to be a real success story. I think we've made some amazing things happen and developed some features that I think you'll see maybe in more detail that we think are really useful for the program. And I wanted to emphasize that a lot of this is really born out of the need to manage and implement a national program. So we have in Malawi 29 health districts. It's obviously mainly rural country with transportation and connectivity challenges. So communication and effective sharing of information is quite a challenge. And there are many use cases that we found, can ideally be addressed with a system like this. And just to give maybe one example, so we publish our draft allocation lists for HIV program commodities for all of the 800 facilities that are currently in the program for review by the facility and pharmacy staff around the country. And so it's been quite difficult to disseminate and notify everybody of a draft list being available, and at the same time then collect feedback and potential corrections to the allocation list before we dispatch the consignments. And so this is one of the examples where we found a system like this that is able to, where users can actually register to follow a specific content category and get automatic notifications when a new content is being posted, not just by email, because many of our colleagues don't regularly access their emails, but also through other means that are more accessible to them. And then obviously review and respond in a short amount of time. So this is one of the examples that I think we had developed, and I think there are many more. I guess Jonathan will walk through some of these, but just to frame, I think, the background and the utility that we were hoping to achieve with this. Back to you, Jonathan.
Thank you, Andreas. It's great to hear your side. And I'm sure, Andreas, do jump in if you think I'm missing anything, and I'm sure you'll be around to help answer questions at the end as well. Yes, so I thought that basically I would show you the site. And you can go there right now. It's available at dms.hiv.health.gov.mw. And it looks something like this. Hopefully you can see that. Is the site being shared now? Andreas, can you confirm?
My connection is a bit slow, but I can't see the site yet.
Okay. Is it slow with updating, or is there a problem with the screen share? You see, I rehearsed this multiple times before everyone joined the call, and it worked, and now it's not working. Let me just stop sharing and try resharing. I see. Sorry, technical problems. Right, I believe everyone should be able to see the
We
site
can
now.
see your screen now with the website. Thank you.
Excellent. I'm really sorry. Great. Well, we got there. So this is what the site looks like. You may be able to follow in your own browser even. The first thing, of course, to note is that there is plenty of content that has been uploaded to this site by the team, which is fantastic. That content is broken down into a variety of different categories. And it includes program reports and strategy documents. It includes policy and implementation guidance. It includes minutes of important meetings, clinical guidelines and standard operating procedures, and also quarterly program data published by the department. Now, you can go to the datasets page. This is the very heart of the system by clicking on datasets, the top navigation. And here you get a long list of all the datasets that have been uploaded by the department. You can search those datasets and filter those datasets. So for instance, let's say that we wanted to get the program. We can search that data. It appears there at the top of the list, and we can download that quarterly data. And as an academic partner, we might use that for our work. Now you can see that that data is also published with metadata. We have names, descriptions, and other structured metadata available underneath. As well as that metadata, we also have an activity stream. Now this is essentially acting as the data audit trail. And from here, we can see who has changed the data set and what they have done and when. Now this data set was uploaded as part of the migration over to the new system. So it was actually uploaded by my colleague Thomas, who also works for Fjelltopp in the early days of the system. But we can see that Tawera from the department made changes after Tomek had uploaded the data set. And the system will be able to show you what those changes were. We can click and see a summary of what those changes were. And we can also go back and browse the data set at that point in time and download the data from that particular point in time. Now there are various features that Fjelltopp have developed specifically for the department, and Andreas mentioned some of them earlier on. I mean, we did a complete revamp of the user interface look and feel to make sure that it met the department's branding and user experience requirements. But as well as this, we implemented short static URLs that can be used in bibliographies so that people can reference a data set from an academic bibliography. As well as this, it's also possible to follow data sets of interest and categories of interest. If you click this follow button, you'll see the follow count goes up by 1. And what that does is it means that any changes published to this data set that appear in the datasets activity stream here will then also appear in my personal newsfeed, so that I can see what people are doing to the datasets of interest across the site. And indeed, as Andreas pointed out, you can also receive emails and SMS notifications with those summary changes in place as well. Now, my newsfeed at the moment is full of changes from Christian Newman, made to a dataset called supply items and a dataset called facilities. Now, the reason for that is that changes are being made every single night to these two datasets because the department have been able to set up their own interoperability between their HIS, their Health Information System within the department, and their data dissemination system, which in our mind was a real success. So every single night, the supply items and the facilities lists are re-pulled from the HIS and re-uploaded to the data dissemination system without any further involvement from the data management team. Now I can click on some of these resources and it should preview the resource within the page. Give it a little bit of time. Like this, so there are tools to enable you to preview the resource, to do some quick graphing and mapping, and there are various extensions and plugins that will help you to deliver this. You could extend this in all sorts of ways to create in-page previews. Now, this is actually been a challenge for the system. So whilst there have been many successes with this system, not least of which has been the number of data sets that the department have uploaded, as well as the collaboration with the team and the stability of the system since handing it over to the department in November, there is still some further work that we want to do and improve. So unfortunately, these in-page previews do not appear for all resources. So we want to develop those. We want to be able to manage private data within this system. This system is only for public data at the moment, but CKAN should be able to manage private data equally well. We just need to set up the configurations and do a little bit of development for that. We want to improve the mobile user interface, and that's because most of the staff using this system across Malawi will be using it from mobile devices. Now, the site is perfectly usable on the mobile, but it's definitely not as slick and nice to use as it is from a desktop. As Andreas mentioned, we also want to add WhatsApp notifications. That's because SMS is notoriously unstable, and it's hopes that that this can provide a really great tool for updating people across the country on the supply items available. We've not done any search engine optimization on this site yet, and systems advocacy. We could do a lot more of that to increase uptake and use. And we also want to do some security patching and upgrade the core CKAN version because a new major version has now been released since the initial development phase. So there's still some work to do, but the site is being used, and that's crucial. So let me just switch back to my presentation screen.
We can see your slides.
Hey, Jonathan, you might be speaking on mute.
Hi, can you hear me?
Yes, now I can hear you.
Sorry. Yes, I was. Yes, so as I was just saying, that we have seen since the system launch in November, 2,900 users visit the site, which is great, given we haven't done any search engine optimization. And the vast majority of those users are from Malawi. There's 172 data sets in the site already, which is great, and that number is increasing. And we have seen 2,200 downloads from the site since November. And the vast majority of those again come from Malawi, but there are a few hundred coming from the United States, UK, South Africa, Ethiopia, Namibia, and the Netherlands. So the site is being used, and if we were to go back and think about that opening story in WHO Romania and all the emails and all the meetings that were being arranged, we certainly believe it has saved an awful lot of time and resources for the department. So what I'm coming into land now. So what should you do having heard this presentation? Well, first of all, we'd love to hear your thoughts on the project. We'd love to hear whether these experiences resonate with your own experiences. Do feedback, do ask questions. Secondly, you could visit the DMS if you have an interest in the work of the Malawi Department of HIV/AIDS and Viral Hepatitis. Do visit the tool, get a sense of how the solution works. Thirdly, you may be interested in the project. You may be interested in considering partnership with Fjelltopp. We are always looking for new ways to increase our social impact. So if you have any software or data engineering challenges, we would absolutely love to have a chat. And fourthly, this is a shameless plug to maybe a very few number of people, but since November, the DHA and Fjelltopp have been looking for a little bit more funding for a second round of development on the tool. And we have a fully approved proposal signed off by the director of the department for system stabilization and advocacy. We've just not been able to secure that funding. So if you or anyone you know of might be able to help with that, we would love to speak to you. So just to summarize, the lack of data dissemination strategy of our work is definitely obstructing progress towards a sustainable development goal number 3, health and well-being. We do believe national health data should be made fair, it should be reusable. We really encourage you to think about how fair your institution's data is and how you can make it more fair. Consider a CKAN data catalogue perhaps as a solution. Fjelltopp can help. We really would love to chat, but thank you for listening. And I'll hand back to Anna.
All right. Thank you, Jonathan. So we've had a number of questions in the chat. It looks like many of them have been answered. If you have a question that you would like to ask, please go ahead. Moses, if you would.
Yes, thank you very much. My name is Moses Bajendera from Uganda. I had a question for Jonathan and Andreas. As you define the data catalog, metadata, you kept on using the word repository, yet I know it is different. I wanted you to categorically mention the differences, repository and metadata data catalog, but also advise on how countries, especially the LMICs, the developing countries, can move from repositories to data catalogs, the requirements needed, and maybe share the Malawi journey. How has it been moving from repositories to data catalog? Thank you.
Andreas, shall I give my thoughts on that first?
Yes, please go ahead. I can add.
Yeah, great. So I think there is an overlap, a small overlap in the scope of a data repository and a data catalog, mostly driven by the particular technical solutions that can be used to deliver on both concepts. But I see the data catalog as very much being the public-facing side to the repository, the interface with which people can engage with the repository. It's about how do you publish finalized and approved artifacts, whereas the repository might be much more about how do you manage and organize and clean and review all of that data behind the scenes. Now, I think in my experience, there are a lot of ministries of health and institutions that are battling so much with that latter problem of having a good data repository that they haven't yet been able to properly think about that data cataloging task. But I think that if you get the data cataloging task right, it will motivate, direct more of the work around how to improve data quality in the data repository. Andreas, do you have anything to add?
Yeah, no, I think this is a really important difference also from our perspective. So I think the cataloging aspect and the presentation and making the data searchable and findable, I think, is a key for certainly many of our domestic users here. And I don't know if you've had time to look around the website, the document management system, but I think one of the things that really struck us with this solution is that it seems so intuitive. It's, it's almost obvious as soon as you look at it of, how you can search and tag and find things. And I think that is really valued by our users. And I think that makes it very different from a typical repository where it's much harder potentially to find things. And, of course, some effort needs to go into the posting of content to ensure that you have, selected the right tags and an appropriate kind of posting note to explain some of the content and summarize the resource. But I think that is the key difference, and I think that's where the benefit where it shines in our case. Thank you.
Thank you. Isa, I saw your hand up. Do you have a question?
Yeah, thank you, Diana, and thank you, Jonathan, for the wonderful presentation. I've asked a couple of questions, and they have been, answered by other folks. But there is one that is striking to me, looking at, the settings where we operate, including Malawi, within the low and medium level income countries. When we are, coming up with solutions or systems, we should also be looking at sustainability. So, and for me, from experience, the best way to think around sustainability from inception or conceptual, planning of any system is to ensure that you do proper stakeholder mapping. And I think from the presentation, I'm very happy to see that the Malawi Ministry of Health is key on this. There is something that I've not seen come out. Just wanted to know about the governance of the DMS, who does the governance, and how is it funded? I know it may not be that extremely expensive, but no matter how little resources are required to maintain this system, we need to know how it's funded so that at least, we will learn from that if it is bilaterally funded. And then lastly, security of, I've asked and I've not seen a clear answer to this, whether or not the DMS, receives person level information or patient level information. And I want to believe that PIIs are excluded if it receives patient level information. And again, we need to know the security measures deployed to ensure that the clients or individual information is not exposed to unnecessary access and use. Thank you, and over.
Yeah, thank you. They're great questions. So the funding came from UNAIDS for the first development. However, I think in everyone's heads, this solution is owned and governed by the Department of HIV, AIDS, and Viral Hepatitis. So even though the funding for development came from UNAIDS, the system has been officially handed over to the department. The department are paying for the ongoing hosting costs already from month to month. And indeed, as I say, Fjelltopps stepped out of the equation in November with a desire to find some more funding for some further work, but we have not had anything to do with it since November, and the system seems to have run stably ever since. So our view on the question of sustainability, it's something that we have wrestled with over the past 10 years that we've been in this field. Our view at the moment is that we solve it with expert industry leading infrastructure practices. So this system is deployed using Kubernetes with quite a bit of work put into the monitoring and the scalability of the tool. It is hosted in the cloud, not in on-site infrastructure, which helps a lot with the sustainability of the project. And it will run for a long time and scale for a long time automatically. Now that doesn't mean to say you can just leave it, because all software rots if you leave it for long enough. And so it will need a little bit of maintenance year on year. But that amount of maintenance is minuscule compared to the development costs. It might be a day or 2 days a month from Fjelltopp or any other technical consultancy with experience in CKAN or Python. I think at the moment I'm quite happy with the sustainability of this system, but I would like to hear from Andreas whether he agrees.
Yes, I totally. I think that the maintenance costs are minimal. This is not something that we've been struggling to fund for the department. I can't speak for any other setting, but I think here for us this is not a concern. And of course, it was really key for us to use an open source solution that doesn't, come with massive licensing costs or any other recurring expenses that might be hard to find and to pay for. Yeah. Thanks.
And then on the patient level information, no is the simple answer. No, we're not putting patient level information into the system. The moment that happens, there's alarm bells going off in my head, of course, and we try to avoid having to deal with that sort of data wherever possible. But there are plenty of security measures in place. Again, industry standard security measures. Data is encrypted at rest and in transit. It's a whole lot more secure than just sharing an Excel spreadsheet via an email. If data is locked down, at the moment all the data is public, remember, so that has massive implications for the security measures that need to be in place. But of course, if data is locked down, it can only be accessed by people who have an individual registered account, and we can track who is doing what and where, and enforce password policies and all sorts of different security measures as necessary to protect the data. But no, I don't envisage a data catalog like this holding patient level information. That it's for a higher level of data. Hopefully that answers your question.
All right. Vinit, you want to go ahead and ask your question?
Okay, thank you, Jonathan and Andreas, for the great presentation. So my question is, like, when I look at like the data catalog is primarily more about the data, like all the metadata, like technical or business metadata associated with the data, and lineage, how the data is calculated, what was the flow and everything. So and it makes life easy as well when you are talking to the ministry or whoever is having the data, that we are not giving direct access to data. We are just showing the information about the data as much as we can. Like the goal of the data catalog, I feel like, should be like, if I am owning the data and you are looking at the data from the other department or from the other place, you should have same knowledge about the data as much as I have. And this should be the goal, and like that it should be reusable, findable, accessible. So once I convince this is the right data set for my purpose, I will contact that data steward or that person to get access of the data. So, and what I can understand with the CKAN, it's like it is hosting the data and you can access the data from there. So what is your thought? Which is the easy way and serve the purpose of the data catalog? Hosting the data itself, or hosting the details of the data as much as possible so that it can be findable and accessible? I would like to hear your thought. And thanks for the great presentation, John.
Yeah, what an excellent point, Vinit. And I made a reference to this when I was talking about those countries struggling with open data. Maybe they could consider open metadata instead. And it's exactly this, that even if your data needs to stay locked down, it's still a great thing to get your metadata out there so people can see what data exists, and then they can see how they need to go about getting access to that data, who they need to make applications to for the necessary approvals. So we're absolutely on board with that idea of saying open metadata is a great middle ground. And I mean, whilst the data cataloging solution is principally about metadata, for that data to be accessible, you need to have a clear path to access, and CKAN provides this because it can host your files and data for you. You don't have to host files and data through CKAN. You can create a data catalog without any data. You can just create the metadata. You could link those that metadata to other systems. It doesn't have to be hosted actually in the CKAN instance. You can just as well add links to other parts of the web, links to SQL data tables, but crucially, that metadata is available, it's searchable, and it's findable. So I mean, I don't think I have a huge amount to add, except I completely agree with you, and I really believe that this is a route that could be really powerful within our sector, is to make the metadata open, even if the data itself can't be made open. And CKAN will help you do that, definitely.
Thank you. Celestine, can you ask your question, please?
So thanks. I think this question has been asked both in the chat and somebody asked, and I apologize. I didn't get a clear answer. But really quickly, is this aggregate data or is it individual level data?
It's aggregate data.
Thanks.
Yeah, I mean, individual level data obviously comes with all sorts of necessary security measures, and we're not getting into that in this project. It's also important to say it's not just structured data. So I know many of us may be thinking within that framework of data tables, relational databases, CSV files, spreadsheets. It is also unstructured data. It's program reports, it's meeting minutes, it's documentation that is related, it's metadata. And CKAN can put all of that together in one repository, which is a particularly powerful feature, I think. Sorry, go on, Dana.
Andreas?
Yeah, I just wanted to add, I think, to this, just to emphasize what Jonathan just mentioned, is that I think a lot of our users will be looking for things like guidelines that we publish. So all of our program guidelines are available. All of the SOPs, they're easily retrievable, as I said, and they can be viewed directly on the platform. So I think all of these aspects are much beyond, I think, what we're thinking of maybe as primary or aggregated data. And yes, I mean, we have not considered, and we are not considering to publish client level or patient level data on this repository. That's not, there's no use case for that, and it certainly wouldn't be acceptable, I think, to anyone. There was a question in the chat box from Jim about the georeferencing and other options that I actually wasn't familiar with TerraFrame. But just to mention that, for example, our facility inventory that's being updated via API every night is geocoded. So it's possible, for example, to use that together with the program that we export to get a fully georeferenced service data set. That's all accessible on the DMS for us. Yeah. Back to you.
All right, I see one more question and we are just about out of time. So if we can answer this one in the lightning round, is what data quality, integrity, use, and accountability issues did we deal with during implementation? Might be a bit long to answer in the next 2 minutes. So you want to take a stab? Or we can go ahead and answer that one offline.
I think a good idea is always to put a disclaimer on your website. We explicitly, when we publish the facility program level data, we have a disclaimer in every document that explains the nature of this data, that it might have flaws, and for what purpose it's intended. So I think that gets around some of these issues, but of course we make a big effort on our side to certainly clean and publish good program data. I think that's what maybe worth pointing out. Yeah, thank you.
All right, thank you. And with that, we are just about out of time. So I do want to thank Jonathan Andreas for your expertise and for sharing. I know we had learned a lot today. And I also thank everyone who participated. Your questions do build the knowledge base. So thank you everyone for being here. We ask that you provide a little bit of feedback on the session, and I will post a QR code and a link, and it will take you literally 2 minutes if you do it slowly. So we do ask that everyone take a few moments to help us enhance what we provide as soon as I can post that. And also you'll be able to find materials for the webinar posted. We have a share file site. I will post that link in a moment as well. We will send by email. So please watch your email for future announcements. Our next webinar is in 2 weeks on the 25th. That one will be on national health data dictionaries. We have hosted webinars on data dictionaries and concept dictionaries before. I'm not a technical expert. I may be conflating two topics, but if those are of interest to you, you certainly may search the data, the repository of information that we have. But we hope to see you again on the 25th. Again, if you haven't joined Shiriki and you'd like to get the notices, let us know. You can always email us at shiriki@cdc.gov. I thank everyone again for attending. I'll leave the connection open for a few minutes, and then we can go about our day. Thanks again, all.
Thank you, Dana.
Thank you. Good day.